We go on to our next speaker, Dr. Nilesh Kanjani, who's a director and head of Vitreoretina department at Dr. Agarwal Eye Hospital, Bangalore. On to you, Dr.
Thank you very much, madam. Yeah, my video is seen, madam.
Yes.
Okay, this was one of the interesting cases which we had, wherein 32-year-old patient who came with the injury of reflect ball, and here you can see lasting was also done in this case. You can see a nice epithelial ingrowth, traumatic vitreosis, subluxated lens, probably with the cellular weakness, which was secondary to the
I think
trauma.
volume can be reduced, no?
Okay, now I think it is better.
Yeah. Thank you.
So in this, the posterior segment, the view was also a little bit hazy. So we're not able to clear what is going on behind. So we, as what we went for a B scan, we can see a classical retinal detachment in this case. So it's a kind of a major case wherein we go with the first step. The first step was to do a safe remove, do a anterior capsular axis. And you can see that the cellular weakness is also there. So we are putting a CTR ring. So once it has to be done very carefully, you can see I'm trying to put it gradually. Okay, and we can see a significant cellular weakness in these areas. Now, all these cases has to be done. This is the most important step. You can see that dye which had almost gone behind came in front. So anyway, we are planning vitrectomy in this case. So once this portion is over, so once the CTR ring is placed, viscoelastic was placed, and we place intraocular lens in it. Preferable intraocular lens in this case because it's a double loop lens and probably it's a quite wide one, and it went easily in the back. So once this portion is over, we plan for the 3-port pars plana vitrectomy. So once the lens is in the place, we waited for some time to make sure it is stable. You can see here, we went for the pars plana vitrectomy. We are able to see the giant retinal tear. So things coming up slowly, more and more things are adding up in this case. So once the went for thorough vitrectomy, and at the end you can see the laser, we injected silicone oil in the same case. So far so good. At the end we also did the scleral buckling as a part of the procedure, because usually trauma cases we do scleral buckle. Now what is the next step? Next step is we have to remove suture the traumatic vitreosis with the 4-throw pupilloplasty. We do the 10-0 Prolene, where you can see the 180 degrees, 2 scleral ports are there. Once this stage is over, pupilloplasty is over. So next is an anterior segment cully coming into picture. We try to lift the flap, and there is the flap is very thin. It's quite old. Surgery was done many years back, and we are trying to remove the epithelial ingrowth. Since the flap is thin, the movement has to be very steady, quite simple. Try to remove as much as possible gently, and make sure that we are not trying to disturb the flap too much. So once the epithelial ingrowth, you can see slowly just moving towards the periphery. We try to lift it till the edge of the flap. And once we do it, we try to remove all the epithelial ingrowth which is there here. So probably it seems that things are much better now. But only thing is that once we try to clean the flap, there's one more thing which was left out, which was a free flap. Yes, we could have marked the cornea and then tried it. So once the cornea is placed once again, then we suture all the ends, and probably we inject air in the anterior segment. And this is the case. And this patient we are following up, patient has almost improved very well to 624 vision, because there are a lot of atrophic patches on the macula. Thank you very much, madam.
Yeah, one amazing video. Like the whole ophthalmology was shown in this particular case. Thank you. But there are some questions here. Why would you want to put a scleral buckle if you have done an endo laser also has been done at the end of vitrectomy? Is question 1. The question 2 is, there is zonular weakness. The silicone oil is likely to come into the anterior chamber. So that possibility again is there. So when that all is there, so could you have at least done a PI? Would that help? Does it make sense? And why did you need to manage the corneal condition? It was an epithelial ingrowth. It was there was not aggressive stromal melt happening, and it's already an inflamed eye, operated eye, so many surgeries done. could the epithelial ingrowth have been taken care even a month after? I mean, these are the three questions I have. I would want, maybe the expert panel could answer it or you could answer it.
Madam, as far as the scleral buckle is concerned, in majority trauma cases, we do scleral buckling many cases, just as to prevent recurrent retinal detachment, or let's say to reduce the PVR. And as far as silicone oil is concerned, the eye, let's say, the retina was not looking that healthy. So silicone oil was placed in these cases because scleral buckle and silicone oil both were done, and silicone oil was later on removed at, let's say, 2.5 months. So anterior migration of the silicone oil probably would not have happened. Very rare cases it would happen. And as far as PI is concerned, the pupilloplasty when we did, there was a partial small PI which was already there on the table. Now the vision was a main factor because it was lying in the central visual axis.
Yes.
So vision was 3/60. Even if I would have done a very good retina surgery and anterior segment surgery, still the vision was a main concern for the patient. So by removing the epithelial ingrowth, patient vision, what is that 624, which we recovered post-operatively, the patient recovered. I would not be able to give the same vision to a patient with epithelial ingrowth because quite significant in the visual axis.
Yeah, but very thin flap, epithelial ingrowth, there has been some kind of a stromal melt here. So you would want a more ideal situation of a very nice quiet eye before we do it. Dr. Arundhati, would you want to add anything about the cornea part of it? And I leave the other expert panel to give their thoughts. Dr. Sai, would you want to say anything? Dr. Meenu?
Yeah, I can talk about the cataract part. In the subluxated cataract is repeating the same thing which we talked about in the first case. In zonular weakness, if you are identifying zonular weakness, either plug that area off with the dispersive viscoelastic and then do staining of the anterior capsule controlled under cohesive viscoelastic to paint the anterior capsule, because you could see that there was no glow. No glow, maybe because of retinal detachment or the blue going underneath. So blue going behind makes it totally dark, and it is very difficult to do if it is a hard cataract. This is a soft one, but that's okay. But then still, it is difficult to operate, and it can be totally avoided rather than injecting. See, under the iris and all, is no need to go under the iris. Small pupils nowadays, I do not go under the iris and stain. I always retract the pupil, put sodium hyaluronate and retract and then stain on the anterior capsule only by putting drop by drop. This is a very important point which I keep in mind in all these small pupils and in areas of subluxation. Otherwise, the rest of the stuff was fine for cataract.
What did you say in a small pupil? You would put sodium hyaluronate?
I would I have seen people putting in 3 millimeter pupil. Just so you can always put blue under the iris and then do I retract the pupil, make it at least 5.5 millimeter. So for retracting, you need viscoelastic. So either if people are putting HPMC, it has to be completely aspirated. It doesn't usually get completely aspirated. It sticks here and there on the anterior capsule. So I put sodium hyaluronate, which can easily be even aspirated, or even without aspirating, we can inject a little bit of saline underneath the visco on top of the capsule, and you get a plane of fluid there. So there you can easily drop it in the stain controlled way.
The only problem there is that you have to, retract the iris first before you do this, isn't it?
Yes, in a small pupil, 100% retract and then only.
So there's one small subset of small pupils which are the uveitic eyes, where you just put in some air and put a very, very minimal amount of trypan blue under the iris, and then by using Kuglen hooks you can just stretch it and they remain like that. In such situations, too much of use of iris hooks will damage the iris even further, and it gets torn here and there. So that is the only situation where I would put trypan blue under the iris and then use Kuglen hooks to do a stretch pupilloplasty, so it remains mid dilated. Other than that, I think what Minu's point is well taken.
Suven's ring, it has now become no financial interest, but it has now become more than 90% of the cases of small people. I only put rings now. Hooks are very rarely put in very intumescent, very shallow chambers, and when they wanted a little more dilatation, I put hooks. Otherwise, I put this, and it doesn't damage the sphincter too much. Only the last one when you put in, if you want to stretch a little bit, it may tear a little. That's all. Otherwise, it doesn't damage the pupil very much, and it remains very nicely round. So, and thanks for creating such a wonderful gadget.
I have another one of the cases to show you all where you wonder about that. There are one odd case where iris hooks serve better. Again, open to discussion when we come to that particular case. I think that case comes now, I think. Thank you very much, Doctor. It was a wonderful combination of cases. Dr. Nilesh, you showed.
Thank you,
Thank you
madam.
very
Thank you very
much. We go on to our, Arundhati did not comment on the cornea issue, which I said.
I think I'm quite okay with what he did, like,
At the same
treating
time.
it, at the same time.
Yeah.
I'm okay. Because you get really tempted to, finish off all the things.
All of the things at once. Yeah.
And it was quite bad epithelium growth. So that I would say.
Yeah. Dr. Satyajit, I want you to raise your hand and ask questions whenever you want.
Yes, ma'am. Yes, ma'am.